emergency and you need to do something in the emergency department. So what are you going to do for them? Remember, pelvis patients will die. Acetabular fracture patients do not die. They limp, they have pain, they will have a lot of pain, but they will be living with pain. These are the pelvic fracture patients are the one who can die in the emergency department, in the casualty or emergency. Why? Because this pelvis is having a lot of organs, a lot of blood vessels, lymphatics, everything is here. So when a force of injury breaks the pelvis, it requires lots and lots of force to break a pelvis. So you always look for shock in a patient of pelvis fracture. Patient can lose 2 liters up to 5 liters complete blood from here if you do not resuscitate it. Always follow the ATLS protocol, which is airway, breathing, circulation, disability and exposure. A, B, C, D, E in that sequence. How do you control the bleeding? Because it's the bleeding which, in orthopedics, it's the bleeding which will cause a death. And that is happening only in pelvis injuries. What do you do in your pelvis fracture patients? If a patient comes to you in the emergency, what do you do? Binder, a pelvic binder. If you do not have a binder, just apply a bed sheet. That is good enough. A bed sheet or a towel, even that can be tied to a patient and it will save his life. In my hospital, we still apply a bed sheet. A bed sheet. No fancy bed binders. No wastage of money. The bed towels are there, the bed sheets are there, we tie them with towel clips. So even that bed sheet can save the life of a patient. You do not require fancy American bought pelvic binders to treat. A simple bed sheet can, even any cloth can. Besides that, you internally rotate the lower limbs. You make patient have internal rotation of lower limbs. That will help him to close the pelvis, and the pelvis will close and the binder can be applied. You can apply some physical devices like these, a pelvic sheet, a pelvic binder, a fancy binder like this, and do the internal rotation of lower limbs. As soon as you rotate the lower limbs, the pelvis closes. It opens up like this. If you close or rotate the lower limbs, it will close. So very easily this closes, and it is also used while reduction of the pelvis intraoperatively. And the other way is, let's say the patient does not improve with a binder. Then what you do? Then you need to do something surgical. You need to do something surgical, which is going to be external fixators. You explore the vessels to ligate them or do embolization by a radiologist, or if you do not have a radiologist who can work and put in the embolization, in my hospital we do not have. So what we do is damage control surgery, which can be packing, peritoneal packing, or a resuscitation screw, which we will see how to do. So, orthopedics, we put in external fixators. So external fixators help us to reduce the volume of the pelvis. It also helps to reduce the bony breakage, so the blood clots can be formed and it becomes easier to control venous bleeding. Arterial bleeding cannot be controlled. For artery which is cut or opened up, you need to either ligate the artery or do an embolization. While this fixator application, arterial bleeding may not come down. As I said, external fixator reduces the volume, increases the tamponade effect. The cancellous bone, it comes together, so bleeding will be less and less motion of the fracture will happen. So more clot formation can happen easily. Otherwise, if it is constantly moving, clot formation will not happen. So where do we apply these pointers or external fixators? Whenever you feel the patient is hemodynamic unstable, that means his blood pressure is down, patient is losing blood, with a binder also you can apply a fixator. And number 2 use of putting in a fixator is when it is mechanically unstable. That means bones are moving here and there. That vertical shear you saw, that vertical fracture, if you do not put in a fixator, it will be continuously moving up and down. So you need to do that. Sometimes when the abdomen has to be opened up, at that time when they open up the abdomen for a laparotomy, then also you will require to put in a fixator, because otherwise it will decompensate and the patient might die. When do you not apply a fixator? Any reason you can think of not to apply a fixator? Okay, good. Anything else? Where do you apply the fixators? Into the ilium? Crest? So, when you will not apply the fixator? Suppose the ilium is broken.
Đi chào thì là thuốc nào không chào được các bạn. Dễ bạn.
See this fracture. The ilium is broken. So if you apply the fixator to the ilium, that itself is broken, it will not stabilize the pelvis. Severe osteoporosis or an enderly fracture, you cannot do that. And if your sacrum is opened up or vertical, you may not have the benefit. One of the cases, vertical shear, you saw fixator was applied, but the pelvis was up. It's because of that, because the forces are not acting. External fixator, usually when the patient is awaiting emergency surgery, you want to aggressively resuscitate him. Speed, you need to apply that very fast. You cannot take 2 hours to apply an external fixator. Many a times when we apply it in the emergency itself. Right there we take 2 pins, put it here, just clamp it and push it on. So do not waste time while putting in a fixator. You do it as early as possible. So which type you put? One is the iliac crest. You put in the pins here, and here. Okay. On the top here, you put in 2 pins here, 2 pins here. That is the way of iliac crest which you can see here. But remember, when we are trying to close the pelvis, we are not trying to close the false pelvis. We want to close this portion. This is the true pelvis. So you want to close here, because all the vital structures are inside the true pelvis. So you want to close the true pelvis and not the false pelvis. So when you apply fixator here, what can happen is, it may close the false pelvis but not the true pelvis. So make sure that it is low down. Where do you apply them? You apply one finger breadth behind. I showed you this gluteus pillar, the thick pillar out here, thickness out here on the ilium. So one pin there and one pin just below, just behind the anterior superior iliac spine, as has been shown here. You can put the frame in whichever way you want. I'm showing you all my patients. It depends from surgeon to surgeon how they have put in this frame. It does not matter, because you are not trying to make a painting out here. You are trying to save the life of the patient. You just want to stabilize the pelvis. So even if you do it in a trapezoid manner, in a rectangular manner, in a triangular manner, whichever way, just close the pelvis. That's what is important. The other type of fixator is supraacetabular fixator. Now supraacetabular fixator you put below the anterior inferior iliac spine, here. Not on the top, here. This gives you closer stability to the true pelvis. It is much closer to the true pelvis, so it gives and closes the true pelvis easily. Hence, if you see the film, one pin on either side is adequate. You can put in one shank pin here, one shank pin here, and close it, and it is adequate. Whereas if you put in one shank pin here and one here and close it, it will break. So the supraacetabular pins are much more stable and closer to the true pelvis, and will give you much bigger and good stability than the crest fixators. How do you put them? You look at this view, this triangular view, which comes in an obturator oblique fashion. When you look at, this is the patient, you put in your image here, an outlet this fashion. So if you look at it this is the triangle which you see here. And this is an obturator outlet view where you can see the SI joint completely up, down, and this is the triangle above the hip joint. So you mark that and then put in a shank pin here. It is a huge area. If you see this, I hold my finger like this. This area which I am holding, inside and outside, this is the thickest portion of the pelvis. Thick. It is a cylinder of 1 inch bone corridor, thickest portion, known as sciatic buttress. If you put in a screw here, it will start from here, come out here. You can put in 2, 3 screws here, from here going up to here, this part. Thickest portion of the pelvis. So this is where you put in the supraacetabular pins. This is the place. As I was showing, in the X-ray it looks like this. From here towards the posterior part, just ensure that you are not going inside the notch, you are going into the sciatic buttress region. So this you need an image intensifier normally to put this. So you can do this only in the operation theatre, not in the emergency. So this is a supraacetabular fixator. These are the supraacetabular fixators which we have applied. You can see only one shank pin here and here. A laparotomy has been done. You can see the laparotomy wound or the scar. And this is the fixator for it. The disadvantage of putting in is, if you see here, this is still not reduced. So that's the thing which cannot happen. Stability is not adequate, but it is life-saving. It is adequate for the time, but it is not a definitive fixation of pelvis. If you anteriorly you apply a fixator, it can open up posterior. So if it is an SI joint, it can open up. And sometimes if you apply the fixator, the general surgeon will say, I have to do a laparotomy, remove your fixator. So that's why putting in an anterior fixator is not advisable. You normally put in a supraacetabular fixator. As I showed you, this one, even if you put, the surgeon has got full access to the abdomen, he can do a laparotomy and he can operate. No problem to remove it. Something is known as a C-clamp. If you want to reduce the posterior pelvis, the SI joint or the sacrum, these fixators will not work. Hence you require something known as C-clamp. This is a rectangular or a C-shaped thing. It is like this. So it is a C or a rectangular clamp. You can see how it works. This is the opening. When you press it, it closes the SI joint. You see this? It closes the SI joint. So where are you applying that fixator? It is being applied here and here, these two places, so that the sacroiliac joint closes on the back. This is one of our cases, acute abdomen. You can see a laparostomy wound, the entire intestines are coming out, they have not closed it, and we have put in an external fixator which is holding the posterior part of the pelvis to hold it. So C-clamps can be put like that. Sometimes if you are very advanced in your emergency, you can put in a resuscitation screw. If you have a case like this, he comes in emergency, you straight away go in and put in a ileosacral screw. And you can see if you put in this gap of the sacrum, SI joint, you can reduce it immediately by putting in a screw straight away. And finally, if not, you do not have anything, you do not have an embolization facility at your hospital, no radiologist is available, you do not have a good image intensifier with you so that you can put in an ileosacral, the best thing to do is pre-peritoneal packing. It is an easiest thing, a life-saving thing, which can be done by orthopedics or general surgeon. You just open up fan and steel, and as soon as you open up the muscles, just put in some mops inside and it will give a tamponade effect. So you put in surgical mops or packs, 3 packs, one on the posterior, one on the central and one on the anterior side, and that will be very effective to close and save the patient's life. We normally do it in our hospital, pre-peritoneal packing, and this is the safest, easiest, fastest way without using any expensive equipments by which you can save the patient's life. So how do you do that? You open up a laparotomy incision like midline vertical or a horizontal. Just open up the rectus as a modified stopper. Put in 2 or 3 mops. As soon as you open, you will be able to put in the mops. It's already made, the space is already there. And you just put in the 3 mops and close your wound. This is going to save tamponade the vessels, the veins, the arteries, and this is going to be full and helpful. If you are in a very big hospital with radiologists available 24 hours every day, then he can do the same thing by embolization, but not so easy possible in every hospital. In my hospital, we do not do this. We do not have a radiologist who can help us with this. So we do peritoneal packing, and it is saving the life of the patient. So what you can do in an acute time? First, which everyone can do. Nobody can say, I am working in a small village hospital, I cannot save the patient's life. Binder or a pelvic sheet can be applied to every pelvis patient. If you have a binder, you apply a binder. If you are in a place where you can put in a fixator, put in an external fixator, preferably a supraacetabular fixator under image. Otherwise, the abdomen will be not open for everyone. If you have the facility, do an embolization. If not, use preperitoneal backing. This is how the sequence-wise you improve and increase the stage and severity of your intervention. Thank you.